You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes. You can also follow us on Twitter at ASAMorg and Facebook. Now, let's go beyond the abstract.
Hello, welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil. Today we're joined by Dr. Honora Englander. She's an Associate Professor of Medicine at Oregon Health and Science University and Director and Principal Investigator of the Improving Addiction Care Team, also known as IMPACT. Welcome to the podcast, Dr. Englander. I want to take a minute just to get to know you a little bit and to hear about your background in treating addiction and researching substance use disorders.
Great. Thanks so much. It's really an honor to be here. My background is that I started my clinical practice as a hospitalist, and I was leading a hospital-to-home transitional care intervention for socioeconomically vulnerable adults, which was a project that I started with a number of colleagues here at OHSU in 2008, 2009, and that was a work that was really trying to address system-level gaps for people who were admitted to the hospital and were very vulnerable around that hospital-to-home transition. And the program was called T-Train, or the Care Transitions Innovation. And over the years that I was leading and developing that work, one of the things that became really abundantly clear as we were doing our ongoing quality improvement was that there was a systemic blind spot to meeting people's substance use needs. And that was driving, my perception and others was that was driving poor outcomes for patients, including hospital readmissions. But then also what I could tell working as a hospitalist and also working in the ambulatory setting was that there were certainly significant financial costs to the way that we were delivering care, but there was also just tremendous human costs, and patients were suffering, and providers were suffering. We've done some qualitative work around provider experience caring for people with substance use disorder, and the idea of really widespread moral distress kind of came up thematically there. So as I was kind of immersed in this transitions work and also clinically immersed in care across hospital and ambulatory settings, just was so clear that we needed to do something differently for people with substance use disorders. And, you know, I saw this kind of across the population, and then there were a handful of patients who just made such sort of a searing impression on me. And one was a young woman who had been hospitalized in 2012 she was admitted with endocarditis and subsequently underwent cardiac valve replacement. And she'd had a series of hospitalizations. I met her, I believe it was her third hospitalization that I met her, and she had been readmitted with chest wall pain, and she was really sort of suffering emotionally and physically. And her endocarditis was as a result of injection drug use. She had an opioid addiction. And, you know, I worked with her and I worked with others at our hospital to try to engage her and help her connect to treatment. But what was so clear was really that we just were not well positioned to do so. You know, I didn't have the resources or skills to initiate her on medication for her opioid use disorder. And more than anything, I just felt a sense of helplessness that I think she also was feeling. And I learned several months later that she actually was readmitted and died in our intensive care unit after suffering a PEA arrest. And it was just a very tragic death. She was a young woman with really sort of so much grace and who was struggling so deeply. And so it was her story and those of many, many others. And then also the effect that it had on the system that we weren't addressing people's addiction in the hospital, that really sort of was a big spark for me to kind of move forward and try to do things differently.
Okay. Now, and it sounds like this IMPACT team developed out of a passion that you had for treating this population.
It did, absolutely. and what happened after sort of the background that I described, which is really around kind of recognizing unmet need, was that I then advocated with hospital leadership. I had developed relationships with some of our key senior leaders through some of the earlier work that I had done. So I sort of subsequently advocated that we needed to at least consider doing something differently, and that the current standard of care, which really was not to address people's use disorders and instead to treat the endocarditis or treat the osteomyelitis or treat the alcohol withdrawal, but not address the root cause. Again, really trying to highlight these gaps. And so I then subsequently advocated with leadership and moved forward to do a needs assessment, both to understand what were the needs from a wide array of stakeholders, including hospital providers, including patients, including community substance use providers and others, to kind of get a sense of what were the needs, but then also using that needs assessment really as a way to engage folks and get buy-in for a process that I anticipated would be a heavy lift.
Okay. And for those that aren't familiar, could you describe the composition of this impact team and explain how the different team members each contribute to the care of these patients?
Yeah, absolutely. So, as I mentioned, we did a needs assessment in 2014, and we subsequently mapped needs to components of the intervention. And so our composition of impact is really sort of a direct result of those findings and that work. And because we lacked the expertise that was necessary to treat addiction in the hospital, and really because patients told us that engagement and trust was such an issue, and that they felt that there was a potential for traumatization in the hospital, and again, that they were really mistrusting of hospital care. We created an interprofessional team that initially included a physician. Melissa Weimer was our initial physician. She's now at Yale. We had a social worker, and then we had a peer with lived experience. And so we had an interprofessional team. We've since expanded. We now have a nurse practitioner and PA as part of our team. We now actually have 3 peers instead of 1, and we have 2 social workers. So it's exciting that we've grown as much as we have, and we have multiple physicians. But we're an interprofessional hospital team. And then the other really key piece of our work is that we have rapid access pathways to treatment in the community. So another need that we identified through the needs assessment was that there was a gap time to treatment. So that if we started a medication like methadone or buprenorphine in the hospital, we understood, and patients told us very clearly that a 2-week wait to get into care was not possible, and so it wasn't going to work for people, and that gap was so important that we overcome with systems design. And so we created partnerships with numerous community partners and really developed that, and so that's grown and evolved over the years. But that's a really key piece of our team.
Great. Now, you mentioned in your paper that hospitalization is, as you quoted it, a so-called reachable moment for these patients. And you have a unique opportunity to engage them maybe a bit more than you would patients that are just in the community. So have you found that this makes a program like yours more successful than other programs that aren't hospital-based?
Yeah, so you're absolutely right. This idea that hospitalization is a reachable moment, and in fact, early on in our planning, that was one of the key questions, because if we were seeing through just administrative data, and we know from national data that rates of hospitalization related to complications of substance use disorder are skyrocketing, and hospitals really are hit hard. But if it's not a reachable moment, we wouldn't have intervened. But really what we found, again, both in our research and in our clinical experience, is that hospitalization for so many reasons can be this golden moment. And partly it's because the fear of death is very terrifying often, and highly motivating for folks. Partly, we've found that by being in the hospital, it sometimes can interrupt people's drug use. It sort of just breaks some of the patterns. And then, of course, having peers with lived experience and having a team that can initiate treatment in real time in the setting of acute withdrawal sometimes, but having a treatment team at the ready is so important. And the other thing that I'd highlight here is just that many people that we see in the hospital are not engaged in primary care. They're not engaged in addictions treatment in the community, either because their lives have so much chaos that it's too challenging, or because of the fears of stigmatization and discrimination that they may have around the treatment community. So there's lots of reasons, but it's a really high risk and really vulnerable group of folks that we serve, both because of the severity of their use disorder and often because they're just not connected to care.
Well, it sounds to me that you've come up with a really great team approach to tackling substance use disorders, and in a setting that maybe others wouldn't immediately think about. And it seems like you've come up with a great team model that could be implemented in other hospitals and healthcare systems. So I want to thank you for coming on the podcast just to discuss this team and to discuss how this idea developed. It sounds like there's really a great future in implementing care teams like this one.
Thank you. Yeah, my hope is that that hospital-based addiction care is standard, just the way if somebody has diabetes or if somebody has heart failure, they get admitted to the hospital. And even if they're there for an infection, we address their diabetes. We address their heart failure. I think the same needs to be true for addiction. The analogy that I have used many times when talking with leadership stakeholders in particular is that, we would never admit somebody to the hospital who had a diabetic foot infection and amputate their foot, but not treat their hyperglycemia, not start them on insulin, not connect them to care related to their diabetes. And unfortunately, the practice of replacing heart valves or treating osteomyelitis without treating the underlying cause of substance use disorders is analogous. And we do have, I guess, the bright spot or the hopeful piece is that we really do have tools that we can use, and I think hospitalists and hospital teams can play a really key role in addressing the epidemic.
Thank you. Those are really some great points, and I know it's given me a lot to think about, and hopefully the listeners can take a lot away from this discussion.
Thank you. Yeah, it's been such an honor to do this work, and I've been supported by so many colleagues across disciplines and across OHSU and our community. We published this description as well as a really detailed toolkit in part to help, or because we wanted to help others in their journey to implement similar work. So hopefully it can be of use.
Well, thank you for being on.
Thanks so much for having me. It's really a pleasure.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.